have our first response kit. We need to check this before each shift. We need to make sure all the drugs are in date, all the equipment is there and not damaged. Up here in the first pocket we have our diagnostics, so we have a stethoscope, thermometer, glucose kit, a peds and adult blood pressure cup, shears, a pupil torch. Down here we have miscellaneous, we have an Inco sheet, and quite often there is an ICP drug kit in there. Down here we have PPE, we have an emesis bag, and we have a local skin anaesthetic. And here we have glucose kits, we have glucagon, syringes, glucose, and everything that we need for diabetes. Around here we have our hemorrhage gear, so we have sodium chloride, tourniquets, gauze bandages, tapes, etc. Inside our bag we have our basic medications, we have antiemetics, analgesics, antihistamines, anti-inflammatories, and also methylfluorine inhaler. And here we have our OPAs, our MPAs, our laryngoscope handle, disposing laryngoscope blades, size 2 and 4. We have adult manual forceps, a hazards bag, and here we have our nebulizing masks and allergy and respiratory drugs. They include prednisone, adrenaline, salbutamol, and all those sorts of things. In the main kit we have a cervical collar, we have splints, we have slippery sand, we have all of our respiratory management, so we have a towel while we're doing respiratory management for positioning the heads. We have our LMA kits, we have our IV kits and our different cannulations kits, our sharps container, adult and peds bag masks, bag valve masks, and yeah. Okay, we're going to check that the cylinder is oxygen. An oxygen cylinder has a black cap and a white bottle, and it should say O2 or oxygen on it. Then we're going to get the regulator, check the Botox seal. If there's no damage on the Botox seal, that's fine. Put it in place. Attach the regulator, lining up the 2 prongs and the clip up the back. Tighten. Then we want to make sure that the valve's off. Turn on the cylinder, and it should come up to around 2000 psi, which is the full mark. We need to run through and check the flow rates, and then look at indications for oxygen. The stats lower than 94%, traumatic brain injuries, carbon monoxide poisoning, decompression illness, and things like that with indications, except for on high-risk patients or neonates. So we're going to attach the nasal prongs to the cylinder, adjust the flow rate. We're going to have between 2 and 4 for nasal prongs. Nasal prongs are good because they're non-invasive. You can still wear them while vomiting, and they can be used for long-term use. So pop the nasal prongs in and put the tubing around the ears and tighten up around the chin accordingly. After you're finished with the bottle, turn the bottle off. And, well, first turn off the flow rate, turn the bottle off, turn the flow rate back on to full, let it bleed out. Once it's finished, turn it back off, and you're done. Here we have our suction system. We need to check that everything's connected correctly. Turn it on, check our battery power, occlude our tubing, and make sure that we have correct pressure. That's fine. We have our patient. He's in a lateral position, or the recovery position you might want to call it. For suctioning, we close this hole with our thumb, and that creates the suction force. We only put the suction as far as we can see, and only suction on the way out in a circular motion. So we'll only put it in as far as we can see, and then a circular motion coming out for a maximum of 10 seconds. Indications for this could be a low GCI reading, GCS reading, altered mental status, spinal injuries, or just anyone that can't manage their own airways and has a lot of fluid or anything like that coming out of their mouth. Before we put the suction in, we should check that there's nothing occluding the airway. If there is, we can use an OPA or a tongue depressor or something like that to scoop anything out. When we're in the ambulance, we do not use the hard-tipped suction. If you must use suction in the ambulance, we use the flexible tip, and for any infants or neonates, we also use the soft suction. Implications can be bradycardia, soft tissue damage, which includes damage to the palate, could have laryngospasms, we could induce vomiting, hypoxia, aspiration. Okay, we have the bag valve mask with reservoir. This is used to ventilate patients, provide PEEP, and provide 100% oxygen. It can be used in bryapnea or in patients with less than 12 breaths per minute with poor perfusion. It eliminates the need for mouth-to-mouth. You use a flow rate of 10 to 15 litres per minute. Complications could include hyperventilation or inflation, gastric inflation, or barotrauma. Components include your masks, there should be 2, your valves, including a PEEP valve, your bag, your reservoir, and your oxygen tubing, and your filter. I don't have an oxygen bottle, but you can check to make sure that the reservoir is not leaking and has no holes by popping it on there. You need to make sure all your parts are present at the beginning of each shift. Then you need to do a Moans assessment when you have a patient in front of you to predict difficult BVM ventilation. So that includes checking your mask seal, if they're obese or have obstruction, age, if they have no teeth, poor neck mobility, or stiffness or sores. So this is a demonstration of a single-handed C grip. So you pop your hand around thumb and finger like a C, and then pop your other fingers underneath the chin. And then to do 2 hands, you do the same thing on top. And then we have our second person. Nasopharyngeal airways, or NPA. The benefits of these are that there is less chance of inducing a gag reflex. They can be inserted into people with a high GCS score. They can be used in lockjaw, and you can suction through the NPA. Indications are GCS less than 8, incomprehensible sounds to pain, or where an OPA is inappropriate. Contraindications can include severe head injury to the base and skull fractures. Complications could be bleeding and inducing bleeding from polyps. We need to measure the NPA from the corner of the mouth to the mandible or the earlobe. Lubricate well, which I won't do on the mannequin. Choose the appropriate nostril, which will be the one that's largest, or both, and insert into the nostril in a perpendicular angle to patient's face, but not upwards. You don't want to force it, so if there's any resistance, you need to stop and leave it or change the other nostril. Oropharyngeal airways, or OPA. Indications for this could be a GCS below 8, incomprehensible sounds to pain, a motor score less than 6. Contraindications could be an intact gag reflex. Complications could be that your OPA is too big or too small. It could cause damage to the palate. It could induce vomiting. Before we insert, we need to measure from the corner of the mouth to the angle of the mandible. This one's about right. Insert gently into the patient's mouth upside down. Pop it in, do a 180 turn, and it's in. At the beginning of each shift, we are going to do an operational check, so we turn it onto manual. We go into our menu, scroll down to other, click on operational check, and run op check. We want to acknowledge that we're doing this. We'll check that our test load is attached. It's now asking us to verify that we have attached it. Push charge button. And press shock.
Shock delivered.
And the shock was heard. Yes, we heard it be delivered. It's going to continue on and run the rest of the check. After your check is complete and everything is okay, monitor passes, at the beginning of each shift we need to check that we have our blood pressure cuff, our SpO2 and CO2, and aspirin, razor. We have our 3 lead, we have our 12 lead. We also have spare printer paper, GTN. We have our beeper pads, And we also need to check that we have a spare battery and that our batteries are charged on here. By pushing the buttons, we've got one that's full and we've got one that's 3/4 full. Hi, I'm Nicole from AUT. Is it alright if I pop some electrodes on your chest and do an EEG?
Yes.
I'm just going to turn that on. I'm going to put RA for right arm up here on soft tissue, not bone. And I'm going to put LA for left arm up here, again on soft tissue. And LL for left leg. I'm just going to pop down here. Is that right?
Yes, that's fine.
So I'll just wait for that to settle. So we can go through the different views. So we've got lead 1, lead 2, lead 3. And then we can also change the volume. So go into the menu button, go into volume, go into QRS. And then you can change the volume. So it's very loud. Then we can turn that off again. And we can go back into menu and go into displayed waves and go into wave 2 and then 2 again. Go up to ×4 and that will change the view, the size. And then we can turn that off and change it into AED mode.
Apply pads to patient's bare chest.
And you can do that with the
Plug in
lead
pads
still.
connector.
And then you can turn off again to this. We have arrived at the scene of a 65-year-old male who has had a witness cardiac arrest. We're wearing our PPE, glasses and gloves, for all our equipment. And as we walk in, we will assess the danger, any possible hazards or obstacles we could trip over. Happy? Happy. Hey, I'm Nicole from AUT. This is Veronica. Veronica, open the bag. Hello? Hello? You awake? Okay, there's no response, so I'm just going to check the airway is clear. Look, listen and feel for 10 seconds for any signs of respiration. Okay, he's not breathing, so we just have conditions if that's okay. Comms need an R50 or a R49. Just gonna put the pads on.
Connect electrodes.
Insert OPA. Turn on my oxygen between 110 and 15, between 10 and 15 liters per minute.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Checking for chest rise. So, what happened with John tonight? Did you see him go down? Does he have any previous medical conditions I should know about?
23, 24, 25, 27, 28, 29, 30.
Again, checking for chest rise. What has he been doing today? Great compressions, good recoil.
30. Yep. I'm going to come around the other side, mate. Ready to take over from me. I can go around. There you go. Just pop the leg up down. Come around the other side across me. Okay, come in. Go.
Okay, we're just going to administer a shock. Stay clear. Everybody clear. Clear. Charging. And shocked. Okay. Three.
25, 26, 27, 28, 29, 30. Twenty-seven, 28, 29, 30. Coming into the last one, dig in. A bit deeper. 25, 26, 27,